Hi, I'm Shalini, one of the GPs from Matthew's practice. This is to Dr. Basu. This might have been covered, but I'm still a bit unclear in my head. So for those who we do medication reviews who are on long-term PPIs and who have not had an endoscopy, when we reduce the dose, they develop the dyspeptic symptoms back. So do we refer all of them for OGD? Am I kind of over-referring? And the second part was those who've had a recent endoscopy, what is considered as recent? Say 1 year or 2 years, can we safely continue PPI for those who've had the endoscopy? Thank you.
Okay. Can you hear me? In terms of the first part to your question, basically, if you have a good response to a PPI, you've got reflux. The question is, do you have Barretts? Now, I think Andy had a slide up, is you perhaps should err on the side of caution by getting an endoscopy for those people who are certainly over the age of 50, particularly male, obese, smoking history, family history, although that's pretty unusual. If you're fulfilling all those sorts of criteria and a more than 10-year history of heartburn symptoms, then they may have a risk of Barrett's, and that's what you're screening for with an endoscopy. As I said, most endoscopy will be normal. There isn't currently the capacity to screen all people with heartburn because endoscopy is expensive, invasive. Cytosponge may be the way of bringing a screening program in. So, no, I wouldn't generally screen someone with an endoscopy if they don't have red flag symptoms. If you've had an endoscopy that was normal, and most people who've got heartburn carry on having heartburn because PPIs don't cure reflux. Reflux is actually a problem with the physiology and abnormal relaxations of your lower esophageal sphincter, usually related to increased abdominal pressure through obesity. If you're still obese, you're still eating in the wrong way, then you're still going to have reflux, which is why it's a chronic condition. Unfortunately, PPI is only licensed really for 4 to 8 week sort of trials before patients then get referred for an endoscopy, because I think there's a question on the computer about length of a trial of a PPI, and it's 4 to 8 weeks. But if you're still obese and eating 3 pizzas a day and drinking Diet Coke, as soon as you stop your PPI, you're going to have reflux back again. That doesn't mean that you've got something else going on or that the PPI has failed. It means your lifestyle hasn't been adjusted. So one of the reasons people get trapped on PPIs is the lifestyle hasn't been sorted out. You'll all be aware there is this phenomenon of rebound hyperacidity as well. If you've been on PPIs for a while, you stop them suddenly, about 40% of patients, their stomach can hyperproduce acid for up to a month or so afterwards, so they get severe heartburn, go back on the PPI, settles down. Isn't it a wonderful drug? They're trapped on them for life. So weaning down in that cohort, patients may enable them to get off it. Does that answer your question?
There's another question just while we're waiting for the microphone from Anonymous. Exactly about that, how long do you trial it for, but also do you trial with high dose or low dose? Well,
I think traditionally you'd start with standard dose PPI for 4 weeks. If you're getting breakthrough symptoms, go up to high dose. By high dose, I would mean you go to BD dosing. So omeprazole 20 once a day for 4 weeks, not working. 20 BD is probably more effective for reflux than 40 once a day. And also making sure you're timing the PPI to half an hour to an hour before meals, rather than after meals or last thing at night, which some people do. So yeah, that's sort of the traditional. And if you respond well, there is no need to be doing an endoscopy. We scope a lot of people in the open access pathway who've had 8 weeks of a PPI, including 4 weeks at high dose. It made no difference to their symptoms. They tend to get referred for an endoscopy to look for other causes.
Please say who you are and who you want to ask the question to.
Okay, I'm Dr. Tradar. I'm a GP with interest in gastro. Does a very short segment Barretts, about 0.5 centimeter, also need regular surveillance?
What centimeter?
0.5 centimeters.
0.5.
I can't say. I feel like the idea about this idea of I think a lot of the open access reports that you get sometimes, you do sometimes get a report that you think, well, hang on, can someone tell me what to do here? And I appreciate the frustration that can sometimes give the primary care team who've asked for the test. But the reason why we call it short segment Barrett's, or less than 1 centimetre, we try to advise people not to actually take samples from anything less than a centimetre, and that's because follow-up, and there's been really good studies, well over 10,000 patients. It's the Oliver Peck team in Germany that just doesn't. If someone says there's Barrett's possible Barrett's that's less than 1 centimetre, the cancer risk is 0. So, well, back to this general population. So that does not need surveillance. So unless there's patients got other symptoms, for example, that need follow-up, then we wouldn't usually survey that. We
validate our Barrett's surveillance, and we often find, when we're looking at the photos, that the diagnosis has been made in error. This is what we call an irregular Z line, or looks like a ton of Barrett's, but it's just an irregular gastroesophageal junction. And the biopsies will show columnar epithelium, same lining as the stomach. You've told the histopathologist you've taken it from the esophagus, so they'll say that's Barrett's, but in fact it isn't. Now, it's important not to label people with Barrett's because it's a pre-malignant condition which carries anxiety, future surveillance endoscopy potential, and can affect their insurance potential for mortgage, life insurance and so forth. So it is important to marry up the photos, the histology and the history together rather than the diagnosis made purely on an endoscopic sort of finding. So I agree with Andy, below 1 centimetre we probably do a disservice, particularly to our elderly patients, of actually making a diagnosis and biopsying. Yeah.
There's a further one on the pad. Any treatment options for functional dysphagia?
There aren't very good amitriptyline is our go-to drug in gastroenterology. And for patients who are very distressed with functional dysphagia, I mean, the important thing is to exclude treatable pathology and organic pathology. And that's sometimes very difficult to do. It's impossible to do with an OGD. It doesn't tell you about motility unless it's very advanced. A barium study can be very non-specific. So high-resolution manometry is probably the default. And it's interesting, a lot of people with functional dysphagia, when you actually do a high-quality, high-resolution manometry and look at it carefully, and sometimes repeat it, you do find significant sort of pathologies. I mean, achalasia can be missed, diffuse esophageal spasm, jackhammer esophagus. All these things do have treatment potential. Now, one of the commonest causes of functional dysphagia is actually reflux that's been missed. We put a nice little probe down the nose for 24 hours and ask people to go about their normal life. No one goes about their normal life with an NG tube down, measuring their acid. They don't eat or drink or exercise, don't do any of the things that provoke their reflux. So sometimes those patients with a negative study and ongoing intermittent dysphagia and heartburn actually do have reflux, and we do then a wireless or Bravo study which can measure reflux for up to 48, 96 hours. And we do pick up a cohort of people who actually do have reflux and then respond, their functional dysphagia goes away. So they need a sort of careful workup before being branded as functional. But generally you're talking SSRIs, amitriptyline, addressing anxiety, IAP service referral, and heavy reassurance. We did have a functional dysphagia not too long ago who had a barium which showed the nodal mass from their lung cancer pressing on the esophagus.
We just got one last question. Thank you.
Thank you. This is Dr. Johnson from Time of Fisher Scientific. Thank you for the really good talks. This is for probably Dr. Andy or Charlie about capsule endoscopies. Are they widely used, widely accepted? Can GPs order them? And is there a preference for any symptoms to prefer the capsule rather than a regular one? And also, what about the costs? Thank you.
You might want to pass that.
I think I might pass that one along. But,
so the capsule I was showing you is called an upper GI capsule. So obviously, when the capsule endoscopy really took off initially for examination of the small bowel. And then that's gone on to, and as things have advanced, an upper GI capsule is a much quicker procedure because the capsule is a faster frame rate, so it takes much more information as it goes through the upper GI tract, including the stomach. And the one that you showed there was actually steerable as well. No, it's not straight direct access at the moment. There's a number of conditions that need to be discussed at the moment, but usually what happens is it's a secondary care referral, and depending on the centre. We're very fortunate to have European pioneers working in our centre, who's Professor Sidhu and Professor McAlinden, to actually sort of take that forward. But I think it's a watch this space, because I think its data's coming. We've already got 80% detection of Barrett's esophagus just on the small bowel capsule as it goes through. So as focus on these tests, I think it's going to be becoming a much more option, and hopefully will encourage more people who are hiding away there with symptoms to come forward, because they know they may get other tests available to them. So not yet, but yeah, it's coming.
Because these toys are brilliant, that's why. And with that, I think we'll close the first session and we'll meet back at 11:30.
Thank you.